Okay. So before I start my talk, let's see the first slide, which is an eye-opener for all of us, because this says the gynecological cancers confers a large burden among women worldwide, and the scenario in India is much more bleak. So our ladies are very much suffering, and you see that almost one-fifth of the women with gynecological cancer belong to the reproductive age group. So this disease is invading our younger strata of the females. So that is the magnitude of the problem. And the Global 22 advisory, they have shown that the incidence of gynecological cancers is going to rise, although they have showed a decline in globally, but that is not the picture in India and other developing world as well. So with this background, let's come to my topic, that's LUT, association of gynecological cancer with lower urinary tract dysfunction, is because of the close proximity of these two tracts. It is very obvious. And just to understand the effects of gynecological malignancy on lower urinary tract function, we have to have certain questions, and we have certain questions in mind, and I will be just trying to answer those queries which come to your mind through my lecture. So how radiotherapy, because these are the two modalities of the treatment, mainly dealing with the treatment of gynecological cancers. So radiotherapy and chemotherapy used in the treatment of gynecological cancers, how they affect the LUT functions, and how specific gynecological cancers per se, they are going to affect the LUT functions. This we have to learn by the end of this session. So that is not simple thing, that depends upon the tumor biology, that is what is the degree of invasion, and any compression symptoms because of these tumors. Then secondly, what standard cancer therapy you have chosen for that particular cancer, like pelvic surgery or radiation or chemotherapy. So, but the evidence shows that radical pelvic surgery is associated with a significant amount of complications and a negative impact on the quality of life. The quality of life is a very important aspect of females, especially in the Western world. We are not very much aware of this problem. That's why the females who are suffering from this cancer, they are not coming to us for improved quality of life. But as a health provider, it's our responsibility to address this issue and just try to improve. So we have to choose the better option for that particularly, that is the tailor-made treatment for that particular age group of patient. There are so many, we all know there are so many variables which have to be taken into account before deciphering any of the treatment modalities to a particular patient. So, although LUT dysfunction can be the presenting sign of gynecological malignancy, but more often the treatment per se is responsible for these dysfunctions. This should be very clear to you. Okay? The dominant LUT dysfunction affecting women following treatment of gynecological malignancy is urinary incontinence. We have been listening all these 4 days about the urinary incontinence, the types. We all are aware with the background knowledge at least. So the next is the genitourinary fistula, which is again a common cause of incontinence. Then other long-term morbidities of these cancer treatments include ureteric stenosis and hemorrhagic cystitis. So we'll be dealing one by one. So now coming to the effect of surgery. Of course, if gynecological surgery for cancer is performed, that it has to be extensive one. And the types are intrafacial hysterectomy, the radical hysterectomy. These are the 2 types. Now coming to the intrafacial hysterectomy and its effect on LUT function. The effect of intrafacial hysterectomy, you see, it may be intrafacial or vaginal hysterectomy for benign conditions we have been all doing. But if it is done for cancer, then of course lymph node, or if not lymph node dissection, but lymph node sampling is a part of the treatment protocol. So that's why it becomes a bit more dissection is needed as compared to a surgery when you are doing it for benign condition. Then second is operative complication of intrafacial hysterectomy have been widely investigated by various authors worldwide. The question, which approach is better, abdominal, vaginal, or minimal invasive surgery or robotic? So we all know that the benign hysterectomy rate of mortality is only 0.1%, but when laparoscopic hysterectomy, although it is very lucrative, but because of the shorter hospital stay, but the complications rates are high as far as the lower urinary tract dysfunction is considered. And it also depends upon the expertise of the surgeon, because if surgeon fails to recognize any injury, then of course the results are disastrous. What are the short-term complications of this hysterectomy? It is uremia or paralytic ileus. Long-term are renal failure, vesicovaginal fistula, ureterovaginal fistula. We all are aware of this. And the incidence of this, which is the organ which is mostly affected, it is bladder. Bladder is commonly injured, and the incidence being 0.8%. Ureter is the second most common organ injured during this type of hysterectomy, and these are the figures which you can see. Then ureteric injury is the most common when radical hysterectomy is performed because of the extensive dissection. It's not so in cases of infravaginal hysterectomy when done for benign conditions. That should be clear in your mind. Then this is, when I searched the literature, I found this largest published comparative study done for cervical cancer, that was radical hysterectomy in 2012 on almost 2,000 women, and they reported no statistically significant difference in bladder and ureteral injury. So the results are conflicting. Then now coming to the postoperative complications, again, minority of studies document some bladder dysfunction after hysterectomy due to disruption of autonomic nerves or because of sensory supply to the bladder. Then but the quality evidence support that intrafacial hysterectomy does not cause any blood dysfunction in the short term, and long term results are awaited, and some studies have, which because of the paucity of time, I can't show you other studies. Then coming to the effect of radical hysterectomy, that is the treatment of choice if you opt for surgical treatment, that is the radical hysterectomy. Of course, it can be a radical hysterectomy extrafacial, or it can be a modified radical, that is Verdheim's, or it can be a radical and extended radical. There are so varieties. Depending upon the degree of organ involvement, we choose the option. But my idea of showing this slide is, it was Verdheim who in 1912 thus did hysterectomies for gynecological cancers as well as for benign diseases. He found VVF in 6.8% and fistulas in 6.4%. But now the incontinent, these fistulas, they have dropped to almost 1% in present scenario. We see less of cases of vaginal fistulas due to cancer surgery. So you see, after radical hysterectomy, you should remember this figure only, that it is 20 to 80% of females who underwent radical hysterectomy for any cancer, gynecological cancer, they will have some sort of lower urinary tract dysfunction. And if you do a short-term study, they will be 80%, but by the course of 15-20 years, they will drop down. Voiding dysfunction in the form of, there can be storage dysfunction. You can all see abdominal straining, slow flow, urinary retention, storage dysfunction, again, you all know. Then recurrent UTI and urinary incontinence. That is the one consistent finding which has all authors have reported, that 20 to 50% of these female find urinary incontinence, and some 12% may be having silently suffering with severe form. So this table is after radical hysterectomy, you can do a follow-up. I just put the different studies by different authors. Some have done 20 years follow-up, and majority of have done a 1-year follow-up. So they all have find fistula, atonic bladder, but impaired bladder compliance, but stress incontinence is the most significant and consistent finding all authors have reported. Bladder dysfunction, majority of urodynamic studies, because this is the urodynamic studies, yesterday Dr. Khwaja was discussing beautifully, so we can understand that for bladder dysfunction and to study the urethral dysfunction, we have to have a flowmetry studies. Urodynamics is a must. So if you do these studies, you can see that Some have studies have noted that stable bladder was stable. Some have found that spontaneous contraction of the detrusor muscles are there, and others have reported a decreased compliance. Okay, so permanent inability to void was reported by one study, that is Kader. He has done a lot of work, and he reported it way back in 1983. So absent bladder and so the results are varied. Different studies have found different results. So etiology of bladder and urethral effects after radical hysterectomy are difficult to decipher, and various studies have investigated the effects of sparing some portion of cardinal ligaments on bladder function because of the presence of abundant rich blood, this nerve supply in the cardinal ligament as well as in uterosacral ligament, we all know, particularly at the site of origin along the pelvic side wall. That's why when the radical hysterectomy is becoming more and more extensive, we go more laterally. So the chances of all these nerves are cut and we have all sort of problems. So less impaired bladder function was documented among patients undergoing radical hysterectomy in whom portions of the cardinal ligaments were preserved. So there's evidence also says that. So these are all nerves which are, one German study argued that the direct operative trauma, edema, they said no, there's no need, this nerve is not solely to be blamed, but because of the operative skill of the surgeon and because of the trauma of after surgery leads to edema, hematoma formation, and scar formation is accounting for majority of the dysfunctions which happen in radical hysterectomy. All studies found diminished detrusor sensation in short-term follow-up, that is less than or to up to 6 months, but it recovered later on. And they first noticed the abnormal bladder sensation. That is the first thing which is very peculiar, which was noted by many of the authors. Decreased bladder sensation can lead to bladder atony, and then again it can be a cause for so that's why you have to be very careful. You have to ask specifically from the patient and do a proper drainage before she goes to have a this thing, incontinence. So you have to intervene before that. This is again bladder changes after radical hysterectomy. They have studied like total bladder capacity, total compliance, and residual volume at 6 months, at less than 9 months, and more than 9 months. And they have found a decreased total compliance and no change in the residual volume. Only one study has reported that decreased volume is there, but rest of them have the conflicting results. So the most consistent urodynamic finding following radical hysterectomy is decreased urethral pressure. That most of the studies they have found. And intrinsic sphincter deficiency is the dominant etiology of stress incontinence following RH. It can arise from mucosal trauma or from decreased innervation, or both of them. So damage to the nerve plexus in the cardinal ligament may be responsible for lost innervation, and bladder, neck, and urethra can become abnormally fixed because of the loss of urethral angle because of the surgery performed, and leading to the loss of intrinsic urethral sphincter deficiency. Again, this table shows the different studies where maximum urethral pressure, functional urethral length was measured, and they have noticed no change. In few studies, there was no change in the functional urethral length, and maximum urethral pressure was decreased after 9 months of follow-up in all the studies. You see, so these are the two important features. A paper published in 2010 in patients of carcinoma cervix showed improved effect on post-operative bladder function, recovery, and the patient's quality after nerve sparing surgery. So this is one thing which we should follow. As try to do a dissection, not to go very lateral if it is required only then, otherwise you can have other options also, that is irradiation, rather than going for extensive dissection, because that is going to hamper the quality of life of the patient as well. Then coming to the genitourinary fistula in gynecological malignancy, these obstetric fistulas were common in the past, as was beautifully, we heard Dr. Zehra's lecture yesterday, so I will not go into the detail. So these were common way back in 1988, and there was a rise in obstetrical fistula to the tune of almost 82%. then there was a drop. But these gynecological malignancy fistulas, they have declined over the years, and this incidence is around 1% only. Radiotherapy for gynecological malignancy also contribute to, we all know that radiotherapy as well as the surgery are blamed for fistula formation. But fistula resulting from pelvic irradiation are more complex because lot of fibrosis is there, and the important thing is the timing of appearance of this fistula. It may be very late, so a long-term follow-up is necessary. A good counseling will help you to achieve that goal. And these fistula are multiple in number. They may be all, if you have examining the patient and you have subjected the patient to a various MRI or USG and you find a fistula, don't jump that I have found one. You should search for other fistulas as well, because they may be multicentric and they refuses to heal also. That's why they are notorious. Then fistula following irradiation can arise months or even after completion of therapy. They have noted more than 20 years after the completion of radiotherapy, fistula development, and patient coming to you as dribbling urine. So effect of chemotherapy, because these are the three modalities of the treatment. So we will discuss the chemotherapy, uh, the function on lower urinary tract, the effect of chemotherapy on kidneys. We all know it is many of the chemotherapeutic agents are nephrotoxic, but I won't go into the detail because we will be concentrating on the lower urinary tract dysfunction that includes the lower ureters and the bladder and urethra. Cisplatin, mitomycin, cyclophosphamide, and methotrexate, and bevacizumab, all are toxic, uh, nephrotoxic. Okay, so the dictum is that you should be very careful when you are administering a chemotherapeutic agent to a patient. Well hydrate her. Careful monitoring, dose calculation is very important, and you can add diuretics so that it is washed away from the bladder, just to avoid one dreaded complication of hemorrhagic cystitis. That is one. So the best known effect of chemotherapy on bladder function is cystitis. And cystitis in general is also common in cancer patients because of radiation cystitis may be there, or it may be because of chemotherapeutic agent, and this cyclophosphamide is notorious for that. So you see almost 40% of the patient, when high dose of cyclophosphamide is given, then the chances of hemorrhagic cystitis are more. So you should be mentally prepared yourself and prepare the patient also to hydrate. So because infusion is necessary, so you should uh, suprahydrate the patient. That is the terminology used for such patients. And the incidence, reported incidence is 2 to 14% of the patients who are receiving cyclophosphamide, because it releases a metabolite acrolein, which is a bladder irritant. So if you irrigate the bladder and hydrate the patient well, then this is going to decrease the concentration of this acrolein and it will be washed away, leading to less of chances of hemorrhagic cystitis. Then another metabolite is I-phosphamide is again responsible for this hemorrhagic cystitis. Platinum, although there are less cases have been reported, but carboplastin, some studies have reported it. So the mesna is the antidote which can ameliorate the toxic metabolite effect of this cyclophosphamide on the bladder. Now, effect of radiotherapy on lower urinary tract function. Radiotherapy is most often used in the management of endometrial or cervical cancer, vaginal, vulval. All these are, they may require at some stage. So most studies on the effect of radiotherapy on LUTs have been done women with cervical cancer. Extensive studies have been done on cervical cancer, the follow-up and all the different modalities. So we can extrapolate these studies result on other cancers as well, because these are the therapeutic agents, the radiotherapy. So we can extrapolate on other this cervical or this vulval or endometrial cancers as well. Blood damage following radiotherapy results from cellular necrosis. What is etiopathogenesis? It causes cellular necrosis of the bladder wall, the migration of this inflammatory marker, that are phagocytes, and they cause the breaching of the support of the urethra and leading to the interstitial fibrosis and vascular endothelial damage. That is the disastrous effect with irradiation. So you have to counsel which method they opt, because if the surgeon is not expert in doing the surgery, then the option left is radiotherapy. in advanced cases. And if you examine such tissues for histology, that is result is fibrosis and obliterative endarteritis. That's why these fistulae refuse to heal, because there's no blood going there, and you need good blood supply for healing. So radiotherapy fistulas are notorious for that. So radiation has both short-term and long-term effects, and they have on urethral function. Short-term are, you all know, fistula, hemorrhagic cystitis, and radiation cystitis. Then late are decreased bladder capacity and lower volume of first bladder sensation, bladder fibrosis, and urethral obstruction is a dreaded complication. So you should be prepared. You can do stunting of the ureters before putting the patient for radiotherapy. These are the other options which can do. Now coming to the one aspect of genital tract cancers, effect of these cancer on the function of lower urinary tract. So we'll be dealing with a few words on vaginal cancer, then vulval cancer, and then the carcinoma of the cervix and endometrial I will discuss together. Though vaginal cancer is rare, only 1 to 2% females suffer, but and the commonest site you all know is posterior wall of upper part. That there's no need to tell. There's no invasion there's no direct invasion. Okay, so if at all it happens, it results in fistula formation, if it all happens. So most urinary dysfunction in vaginal cancer result from disease rather than treatment other than disease. Okay, disease doesn't metastasize or involve the surrounding structure. So when you treat, because surgery is not very well performed, because of the you can't remove the whole vagina because of the proximity of other bladder and rectum posteriorly. So the better option is a radiotherapy. Okay, you all know. So this is the one of the dreaded complications: vaginal stenosis, stricture formation, urethral stricture. They are all common. Okay, so and bladder dysfunction, I have already discussed at a greater length. They are similar to the surgery. And the one study in 1996, they reported radiation complication over 20 years. They have studied their patients for 20 years, and 90% incidence of radiation complications were there. We are all aware, but you should remember that it is the 19 to 20%. Other complications are RVF and vesicovaginal fistula, rectal strictures and ulcerations. I have already talked. Then coming to the cervical cancer, because the modality of treatment which we offer to these both cancers are almost similar. That's why they are discussed together. The tumor compression of the ureter leads to obstruction. If tumor is big enough, you should see by putting the patient on a probe, or if MRI is indicated, which is rarely required, ultrasound is sufficient to diagnose. And the clinical acumen, you have to just expertise how to diagnose these cases. Then uremia causes at least 50% of untreated cervical cancer death. You all know that death of the cancer cervix occurs if uremia happens. Yeah, तो lateral extension होता है because of the lateral. How this disease spreads, cervix? It has a propensity to expand laterally rather than anterior and posterior first. That's why if uremia happens, then the patient is already in the late stage, and death occurs because of that. Then coming to endometrial cancer, primary urinary complaints are rare, and radical hysterectomy and radiation therapy lead to similar urinary incontinence. You all know 20 to 80% of the patients, no matter what modality of treatment you have instituted, they will have some degree of incontinence on follow-up the patient. And advanced stage, again VVF. Bladder dysfunction, 4%. Then there's a study I would like to just share. In 1990, Kim reported 4% of his patients had bladder invasion out of 300 MRI. Okay, only 4%. So it is a late feature. Then cystoscopy is a standard staging method, but MRI is more reliable in detecting subtle changes in the bladder mucosa because of the invasion. Then cervical cancer may cause bladder overactivity. Again, mechanism is not very clear. And there may be overactive bladder pre-treatment. There are different studies with conflicting results. They have found overactive bladder prior to treatment, the percentage was less, of course, and then post-radical hysterectomy, the percentage increased. So you can't say, but you know that they will have some sort of detrusor instability. It may be hypotonia or it may be detrusor overactivity leading to dysfunction of this thing, emptying dysfunction or storage dysfunction. So urethral dysfunction is almost always treatment related in cervical and endometrial cancer. Direct invasion of the urethra is rare, you should remember. So urethra is never ever involved in cases of CA cervix or CA endometrium. And fistula, if at all develops, it is between the uterus, ureter, and not between the urethra and the vagina. That is one important point. I have just marked it. Then urethral resection for incontinence is ineffective because there is sphincter loss mechanism. That is the problem. So that has to be addressed instead of resection of this urethra. Then coming to the vulval cancer, because nearly 50% of these cancers develop within the margin of 2 centimeters of the urethra. So despite proximity, the LUT is hardly involved. Fewer than 10% of patients only experience dysuria, and urethral obstruction is again rare because there is no involvement. Then what are the surgical impact? Because I told you, because you can do a surgery for this removal of to remove this growth, and most treatments require a 2 centimeter resection of the margin, leading to urine stream misdirection. That is very important thing which has to be discussed prior to planning the treatment for that particular patient, that you will have this problem, you may have this problem. So post-treatment incontinence is again 4 to 24% after radical hysterectomy, and because it is because of the pelvic relaxation and there is loss of angle of urethra. These are the problems, and urethra may prolapse or there is stress urinary incontinence. Then 5 to 50% of patients develop incontinence and not associated with pelvic organ prolapse because of this loss of support. Okay, there may not be prolapse, but they will have loss of this angle and hence SUI. Bladder dysfunction. Detrusor dysfunction in vulval cancer is almost always due to radiation therapy because of close proximity of the bladder to the vulva and unavoidable spread of the external beam radiation. So all the problems are because of proximity of these two tracts, genital and the lower urinary tract. The bladder effects are minimal. Urethral dysfunction, bladder outlet dysfunction is noted in cases. In this case, again, bladder incontinence, this sphincter incontinence arises because of altered vascularity or because of denervation or because of mucosal damage, urethral mucosal damage, or because of periurethral edema and dissection and fibrosis. These are all blamed. I have already talked about that. And you should remember that the distal half of the urethra plays a crucial role in maintaining the continence. So try not to disturb that while you're doing a surgery. Damage to this area will result in incontinence in any way. Now, this is a very important entity of one of the complications of radiotherapy as well as chemotherapy. So I will just talk about for 2 minutes. Uh, you know, the radiation, chemotherapy, and infection, any of these things can precipitate this hemorrhagic cystitis, and it is the most severe form of cystitis ever known. So you should know how to recognize and how to manage it, because it may be fatal in 2 to 4% cases. So, and you should, while you are seeing that, oh, this is the hemorrhagic cystitis I found, that may be a development of the tumor itself in the bladder. That should not, you should always keep this finding also in mind. Two things may be present together. So, and if she's having other comorbidities or other coagulation issues, then the problem becomes more severe. Okay, so you better done a coagulation profile, CBC, they are important. Arrange for blood. In severe cases, you need transfusion also because the patient may become hemodynamically unstable and you may lose the patient. So you have to act prompt, recognize the condition and act promptly. Suprahydration, and just put a 3-bore catheter, urethral catheter, and instill cooled saline for flushing the clots. And if need arise, you do a cystoscopy. If the symptoms are not relieved by cool saline irrigation, then it means she is heading towards the moderate or severe variety. So you have to act promptly, secure a line, transfuse blood, and do other measures. Surgical intervention in the form of embolization or occlusion of the ureters so that no urine flow is there. And you can, in remote cases, you may need to do a cystectomy also. And transposition of these ureters into the ileum. So these are the different options, viable options. So you have to recognize the situation, but whatever features are there, what the etiology may be radiation therapy or chemotherapy or it may be infection. But etiopathogenesis, the findings which you get are the same. That you should remember. If you get the findings, then act accordingly. First, make the patient to come out of this drastic situation and then do other things. So this is the these are the features of cystoscopic finding. You can see bladder mucosa is angry looking, erythematous, edema, ulceration, and necrosis and hemorrhage are seen. And then when you do a probe, ultrasound probe, will show a thickened bladder wall. See, this is the bladder wall is thickened and it has multiple clots in the. So you have to remove those clots by irrigation with cool normal saline. And when you do a histopathological examination, again macrophages, inflammatory markers will be seen, and a smooth muscle necrosis is there. That's why you should intervene early. Preventive strategies. One is antidote is mesna for to revert back the toxicity of cyclophosphamide. Then suprahydration, irrigation, and first step is to remove blood clots. If bleeding persists, do cystoscopy to remove further clots and see if any bleeding points are there, and then fulgurate then and there. Okay? Then hormonal options are there, but estrogen can be given to stop bleeding. So only oral medication, literature says only oral, you should opt for oral medication only. And alarm installation, and in severe cases, when the patient becomes hemodynamically unstable, so vascular interventional radiation, selective embolization of internal iliac, and then other options are ileal loop diversion, uterosigmoidostomy, that you just take out the ureters from the place and then implant it at some other place, which is very feasible for that particular patient, because you have to choose, see other comorbidities, age of the patient, other comorbidities, and then you decide which surgical option is better for that particular patient. Now, take-home message is cancers of the female genital tract and lower urinary tract are linked because of the proximity. These cancer treatments often cause lower urinary tract dysfunction more than the cancers themselves. These morbidities and sometimes mortality, as you see in hemorrhagic cystitis, is because of the treatment rather than the disease itself. So you should be aware of that. And urinary incontinence is the leading morbidity post-treatment, 20 to 80%. Okay, follow-up में आपको कम मिलेगा, but to the tune of that. So surgical improvement has reduced the fistula development, but urinary incontinence remains a common cause. Both radiotherapy and surgery can cause urinary incontinence due to nerve damage, surgical trauma, radiation effect, and tissue loss. That is urethral resection. Then age is a key factor in urinary incontinence related to gynecological malignancy. It's not solely to blame the malignancy, because with the hypoestrogenic state, other factors also come into play. So you have to take into account the age while you are counseling the patient. कि सब कैंसर की वजह से, it's not because of only cancer. You have aging process, there is laxity, so you have to bear with it. Whatever surgical options are available, we will try our level best to help you. Now, cancer treatment are continuously improving as we are in the era of technology. So we are striving hard to just come up with all the gadgets and treatment modalities which are available to us. Then blood dysfunction and incontinence are major morbidities, hemorrhagic cystitis, you all know. And then patients generally prefer morbidity over mortality. This is an important thing, and are satisfied with their outcomes. In spite of all the morbidities and in some cases mortality associated with the treatment of cancer, even then the patients opt for treatment because there is a hope that they will live, if rather than just unattended and Okay, so they prefer morbidity over mortality, and that's why that. Thank you all.